This guideline applies to people with rheumatoid arthritis, systemic sclerosis, idiopathic inflammatory myositis, mixed connective tissue disease, and Sjogren's disease. The core team felt that of all of the rheumatic diseases, these 5 diseases are at highest risk of developing ILD. But it was also recognized that across these diseases and within each of these diseases, the risk of developing ILD and then the risk of ILD progression varies quite considerably. So, in terms of who should be screened, it's recommended that nearly everyone with systemic sclerosis and mixed connective tissue disease should be screened because most of these patients will develop ILD, and certainly all of them are at high risk of developing ILD. However, the risk of developing ILD in rheumatoid arthritis and Sjogren's disease is less. And so the core team and voting panel felt that in this situation, it would not be appropriate to recommend screening of every patient with rheumatoid arthritis, but rather a risk-based approach should be taken. And so screening should be a discussion at the level of the rheumatologist and with the patient, and take into consideration potential risk factors. Now, to help with this, the guideline paper will include a table of risk factors that might guide a rheumatologist's decision to screen. And so, for example, in the setting of rheumatoid arthritis, that might include the presence of a rheumatoid factor, CCP antibody, if the patient smokes, has an older age of onset, or high disease activity. Similarly, risk factors for the other diseases are presented as suggestions, but this is not a comprehensive list by any means, and no rheumatologist should feel limited to using this list of risk factors to decide whether a patient should be screened. I think the bottom line is if there is uncertainty about whom to screen, a clinician should proceed with screening. The screening tests are pulmonary function tests and a high resolution CT. And I should qualify that pulmonary function test is not spirometry alone, but also includes lung volumes and diffusion capacity. These same 2 tests are also recommended for the monitoring of disease, but what's new that rheumatologists may not be aware of is that in the monitoring of ILD, it's also recommended that patients have ambulatory desaturation testing. This is a test that most rheumatologists do not perform in their clinic, and this is recognized. But rather, I'm highlighting this for you now because while screening may lie in the domain of the rheumatologist, once a person is diagnosed with ILD, we highly recommend co-management with pulmonologists. And so while ambulatory desaturation testing is not part of routine practice for a rheumatologist, it is a regular test done by pulmonologists, and this is to highlight the importance of co-management with our colleagues. There are tests in this guideline that are conditionally recommended against. There is a conditional recommendation against chest x-ray, 6-minute walk test, ambulatory desaturation, and bronchoscopy. Now, their caveat is that there may be instances, rarely, where these tests may be considered. So, for example, if a patient with scleroderma has difficulty doing a pulmonary function test, or it's an inadequate PFT because they're having difficulty achieving a good seal around the mouthpiece, well, then one might consider ambulatory desaturation testing as a screening test. Similarly, one may consider a bronchoscopy if you need to rule out infection or sarcoidosis, lymphoma, or alveolar hemorrhage. But the bronchoscopy is not meant to be a screening test for the ILD. There is a strong recommendation against surgical lung biopsy as a screening test or even a monitoring test for ILD. The rare circumstance where a surgical lung biopsy may be required is that you're trying to rule out malignancy. The frequency of screening tests is not addressed in the guideline, but really our feeling is that a risk-based approach should be taken between the rheumatologist and the patient. So if the patient has risk factors, then they should be rescreened in the future. Where the guideline does provide suggestions on frequency is for the frequency of monitoring tests once ILD is diagnosed. And so I do want to differentiate the difference between a recommendation and a suggestion. The recommendations are statements for which the evidence has been reviewed and the expert panel has voted on this, taking into consideration patients' values and preferences. And it was felt that the frequency of monitoring tests was beyond the scope of the guideline. However, it would appear to be a logical question, just like you're asking. Frequently should I monitor someone? And so for that reason, the voting panel did give suggestions on the
Ah,
frequency of monitoring. And so that's provided in the figure or the graphics that accompany the paper. And just to summarize for you, so patients who have idiopathic inflammatory myositis and systemic sclerosis, the diseases with the highest risk of ILD should be and highest risk of ILD progression should have their monitoring tests every 3 to 6 months in the first year, and then
oh,
less frequency once the disease is stable. Sorry, that should be the pulmonary function test. Whereas rheumatoid arthritis, Sjogren's disease, and mixed connective tissue disease that's not scleroderma predominant, they should have PFTs every 3 to 12 months for the first year, and then less frequent once stable. The ambulatory desaturation testing is suggested to occur every 3 to 12 months, and the high res CT is suggested as needed based on patient features. Recommendations for first line ILD therapy are presented by disease: sclerosis, myositis, MCTD, RA, and Sjogren's. In the process of developing these guidelines, the voting panel had to comparatively evaluate two treatments at a time, one versus another. And so the consequence of that is that we have a hierarchy of treatments that one could consider. The way to think about this is the principle of transitivity. If you know that A is greater than B and that B is greater than C, you can infer that A is greater than C. However, when the voting panel discussed these treatments by disease, it became apparent that the voting panel and the experts don't want to mandate which treatment must be used first, but rather within the list of therapeutic options would consider, there are some that are preferred, but if they can't be used for a variety of reasons, then there are other additional options that one could consider. And so to keep this whole thinking process transparent to the reader and to the practicing rheumatologist, the graphic that we present identifies, number one, all the treatment options one could consider, but then we also identify which ones experts would prefer versus which ones would be considered additional options. And so what you might notice is that mycophenolate comes out on top across all five of the diseases. And so experts would strongly consider mycophenolate as the first ILD option. However, if they would consider things like extrapulmonary manifestations, cost, access, toxicity, and so for that reason, the other options are also presented. Glucocorticoids are conditionally recommended in the short term for myositis, mixed connective tissue disease that's not scleroderma predominant, rheumatoid arthritis, and Sjogren's disease. However, there is a strong recommendation against the use of glucocorticoids in the setting of systemic sclerosis, ILD, and this is because of the risk of inducing a scleroderma renal crisis. Now, it seems to me that most rheumatologists are aware of the risk that glucocorticoids confer in patients with systemic sclerosis, but this may be new to our pulmonology colleagues. Many of them may not be aware of this. And so here's an opportunity where, when we're co managing patients, perhaps rheumatologists may want to include this in their consultation notes to educate our colleagues that we strongly recommend against the use of glucocorticoids, both as first line therapy as well as use of glucocorticoids in patients who have progressed after first line therapy. For first line ILD therapy in diseases other than systemic sclerosis, we do conditionally recommend short term glucocorticoids. However, the converse is, well, there's a slight differentiation in people who have progressed after their first line therapy. So in the patients who have progressed, there is still a strong recommendation against long term glucocorticoids in patients with systemic sclerosis. And there is a conditional recommendation against long term glucocorticoids in patients with myositis, MCTD, rheumatoid arthritis, and Sjogren's. However, short term glucocorticoids can be considered in those patients as a bridging therapy while you're waiting to access new therapy, or while you're waiting for a DMARD to take effect, or if a patient is having a flare of their ILD. But really, we're looking at less than 3 months duration. We really want to limit. Long-term glucocorticoids should not be considered as a treatment for the ILD, but rather as a short-term bridge. a patient has severe disease or you have a high suspicion that the patient has anti-MDA5 antibodies, there's a conditional recommendation for the use of intravenous glucocorticoids plus two additional therapies. And so traditionally, we would have used cyclophosphamide, rituximab, or mycophenolate. However, the voting panel had concerns about the risk of concomitant infection or sepsis. Usually, these are the patients we're seeing in the ICU, they're intubated, they may be on pressors. And so, if they were to develop a concomitant infection, the use of cyclophosphamide and rituximab becomes complicated, or conversely, the use of rituximab or cyclophosphamide may put them at increased risk for an infection. So the voting panel also conditionally recommended the use of calcineurin inhibitors, IVIG, or tofacitinib. And this is a situation where the use of tacrolimus and IVIG with glucocorticoids is where practice is changing in advance of the data. And so these guidelines reflect this change in practice, even though there is very little data to support this. When it comes to progression of disease, I think if someone has failed their first line therapy, what we conditionally recommend referral for lung transplant evaluation for at an appropriate time and to an experienced center. Not everybody will have access to an experienced center, but the patient panel told us that they would be willing to travel if needed to be seen at an experienced center and that they would value referral. Now, in the setting of rapidly progressive disease, these are patients that really do have poor outcomes, and that the medical management may just be a bridge to transplantation. And so, early referral to lung transplant center should be considered in these patients.